Assalamu alaikum everyone. Hope your days are going great. So I'm Mohammed Albitar, a fifth-year medical student, and our lecture today is enzymes in clinical diagnosis, also called clinical enzymology. And this lecture is very easy. There's not a lot of memorization, just like quite a big table at the end. That's what you need to memorize. The other is just understanding the concepts. Okay, so these are the objectives. So first we have to understand the different aspects of the clinical application, how they apply. Of course, you took already 3 lectures about enzymes and basic stuff. Now we just put them into clinical use. Now we have to understand what are the isoenzymes, how do we measure enzymes, serum versus plasma, examples of enzymes, and which disease we measure which enzyme. We look at cardiac, liver, bone, pancreatic enzymes, all in all. So first, what are enzymes? Of course, you have no, not the enzyme. Basically, they are proteins. So whatever affects the protein in terms of pH, temperature, denaturation can affect these enzymes. So basically, they increase the reaction. So there is a reaction. This reaction rate and speed will be increased by the enzyme, in contrast to being not catalyzed by enzyme. Now, every enzyme has a specific substrate. Multiple enzymes can have the same substrate. Same enzyme can have its exact substrate. Now, each enzyme is tissue specific. So we'll see that each enzyme will be in one tissue. The same enzyme can be in another tissue, but in a different name, whether it was 1, 2, 3, or in a different name, but it's the same reaction, but different tissue. We'll see that later, but it's basically each enzyme has a specific tissue to work in. This is the outline of today's lecture. So first we have to focus on the diagnostic, therapeutic, and laboratory use of enzyme. Our main focus will be the diagnostic use of enzyme. Therapeutic, just giving enzyme as in terms of replacement, or laboratory in terms of we'll use it in the labs. But basically the most important thing in this lecture is the diagnostic aspect of the use of enzyme. Now, there are 2 ways the enzymes can be altered. This is the normal enzyme levels. The enzymes can be increased, they can be decreased. Causes of decreased enzymes level can be whether deficiency of the raw material to make the enzymes, if you have malnutrition or whatever, or if you have deficiency in this gene, this enzyme because of a gene mutation. And we'll get to that. This is the first idea. These mostly they're inherited disease. As I said, you have gene mutation causing lack of the enzyme or decreased activity of that enzyme. The second cause is increased level of enzyme. And this is basically what we're going to focus on in this lecture. What are the causes of increased level in the blood? Basically, if there is a tissue damage, then these enzymes that are inside the tissues, the tissues like has cells. These cells have enzymes. Now, when you damage the tissue or the cells, the enzymes will leave the tissue and cells and go into the blood. Or if you have a trauma, okay. This is what I was saying. So less than normal level can be because of decreased sensitivity. Like if you have any malnutrition, liver is not able to produce enzymes, whatever was the cause, or you have the inborn error of metabolism. As I said, you have gene mutation causing lack or absence of the enzymes or decreased activity of the enzyme. The second one is higher than normal levels of the enzyme, cell damage or trauma, or increased cell proliferation. Because when you increase cell proliferation, like in terms of cancer, you have more cells. The more cells are susceptible to be going into cell death as normal turnover. So you're going to have more than normal levels of the enzyme. Now we'll focus on this one, inborn error of metabolism now. So as I said, it's inherited mutation in the enzymes, genetic material, there's mutation. We don't have the enzyme. So what will happen? The substrate is here. Enzyme convert the substrate into the product. Now, if you don't have the enzyme, then the substrates will be accumulating. And there's different diseases. You will get into them during the next lecture. This is not the focus of this lecture. Here are the diseases, whether it was in the carbohydrate metabolism, amino acid metabolism, urea cycle, fatty acid oxidation, purine. These are all example of diseases where you have gene mutation in the enzyme. But you get into them later on, and each disease has specific features and characteristics. Going back to what I was saying here, these usually inborn error of metabolism usually present immediately after birth. So the child is born, immediately, couple of weeks, months, you see the manifestation of the disease. Now during the pregnancy, the fetus has normal levels of enzyme because he's getting like all the material from his mother. Okay, it's not going to be affecting anything during the fetus development, but once he's born, it's going to have an impact on him. So as you took probably last semester, phenylketonuria. So basically you have deficiency in the enzyme phenylalanine hydroxylase, which converts phenylalanine. Now, if you don't have an enzyme to degrade the phenylalanine, you're having accumulation of phenylalanine. Now, this accumulation, you have to get rid of it in a way. It's going to be converted to ketones, phenylketones. This will give you the symptoms of phenylketonuria. This is a quick example of one of the inborn error of metabolism. And of course, you have newborn screening programs for these inborn error of metabolism. As I said, you have, whether it was in the carbohydrate metabolism, there's a problem in the enzymes there, problem in the enzymes of amino acid metabolism, urea cycle, etc. This is not the focus of this lecture, but just understand the concept that these are the inborn error of metabolism. Now we finished the causes of less than normal level of enzyme. Now what are the causes of increased level of enzymes in the blood? As I said, cell damage or increased cell proliferation or trauma. But just to understand first the concept, now in any normal individual, if you took blood from them, you're gonna have normal level of these enzymes. No one has zero level of enzymes. Of tissue enzymes. You know, if I took my blood, I'll have enzymes of liver. They're normal in the blood in a specific range level. Cardiac also, I'm gonna have small levels of cardiac enzyme. Everything is normal. Why do I have this small level of enzymes in the blood? Although everything is normal, there is no tissue damage, nothing. Now, because it's cell turnover. You know, new cells are being generated from mitosis, whatever, and old cells, like they reach their age, they get apoptosis or die. Basically, when they die, just they release the normal level of enzymes in the blood. This is a normal thing, and it's a constant level. This is one of the causes of having enzymes in the blood. The other cause of having enzymes in the blood is enzymes that actually acts in the blood. So we have enzymes that act in the blood vessels. So they help in the formation of blood clots. And this is a role in blood coagulation. These enzymes are needed to be in the blood always. Okay. And then usually they are secreted as a inactive level of enzyme. So liver releases these enzymes in the blood, coagulation enzymes for the blood. They release them into the blood as terms of zymogen, inactive enzyme. And then when there is injury, bleeding or anything, they get activated and give us the coagulation and the clot. So these are the two ways where we have levels of enzymes in the blood, and they are normal levels. First one is the normal cell turnover of all tissues, cardiac, liver, whatever. We're gonna have low level of these enzymes, and enzymes that has actual role in the blood. They need to be in the blood. That's, as I said, you have cancer patients, they have more likelihood of having increased level enzyme. Why? Because they have more cell turnover than normal of what we see in healthy individual. This is what I was saying. Normal cell turnover, old ones just die, cell necrosis, apoptosis, death. This is how it gets released. While if we go into abnormal pathological cases, whether it was trauma or disease in any tissue, cardiac, liver, whatever, more levels of dead cells, more levels of enzyme will be released, more than the normal. Normal, like for example, 2 pieces. Here we have like 10 pieces or so. So yeah, that's what we were saying. When there is tissue damage or cell damage, whether it was in terms of death because of lack of oxygen, whether of toxins that kill the cells will just release the enzymes into the blood. And this is give us an indicator that this tissue is damaged or has a problem in it. Like not specific problem, but just there's a problem in this tissue, whether it was, we'll get to the causes. And it has an organ specificity. And we know which organ is damaged by checking the levels of that organ. Of course, this is a quantitative, both qualitative and quantitative. When we measure enzymes, qualitative, we know which organ is affected because we know that this enzyme or for this organ it's more than normal, and it's quantitative because if we see very high level of enzyme or there is a severe injury, if we saw just like high but not very high, a high level of enzyme, okay, there is an injury, but it might not be that severe or might not be that advanced, so it just give us an indicator of how severe the damage as well. Of course, these enzyme tests are non-invasive. You can get the result within like an hour or so, and you can repeat them, and they're like usually cheap. So that's why when we just treat the patient or the patient has a problem in the liver, hepatitis, liver enzymes are high, we treat him, we follow him up, we check the liver enzyme, or they're going down. Okay, so the treatment is working well. At this point, does anyone have any question? All right. If you have any question, just stop me any point anywhere and I can gladly answer you. So this is a quick concepts here, like the activity of enzyme. We measure it in something called international unit. So one international unit equals the amount of enzymes needed to catalyze 1 micromole to the product per minute. So if we increase the number of international units, that means that there is more enzymes needed to do this one job. We have also a quick concept here where what's the difference between plasma and serum? Of course, by now you all know. So basically, there is 2 tubes. We took blood from the patient. We didn't put any anticoagulant. Okay, what will happen after a couple of minutes? It's just gonna form a clot in the bottom. This clot is basically formed from RBCs and clotting factors. They form this clot. And the rest of the thing that's happening up in the tube, the yellow one is the serum, deprived of RBCs and deprived of clotting factor because a clot is formed down there. Now, if we take the tube and blood of the patient, we put anticoagulant. This will prevent the coagulation and will give us something called plasma. Plasma, which is basically deprived of only RBC and the other white blood cells, but it contains clotting factors. These are proteins in the blood that are needed for clotting. They are contained in the plasma. So if you think of it, which is more better way to get the enzymes level, by using a serum of a patient or by using a plasma? Now, of course, serum is better. Why serum is better? Because serum is just you got rid of the coagulation factors and protein. You got rid of them. They're down clotted in the clot down there. So it's not going to affect enzyme measurements in this serum. While if you took the plasma, there is clotting proteins and factors in the plasma. So this might alter the the amount of enzymes you're gonna check. In terms of lab, this is all lab stuff. But of course, they're used interchangeably. Okay, so if you're in need, you can use serum, you can use plasma. But which is better? Of course, serum is better. Um, so as I said, because clotting factors might interfere with the measurement of certain enzymes. Clotting factors are protein, enzymes are protein. So certain enzyme you can get, the lab can get confused, the machines of lab can get confused in terms of quantifying the enzymes levels. Okay, so now we go into the concept of isoenzymes. Isoenzymes. So iso is means same. Isoenzyme, same enzyme. So enzymes that has the same reaction. Okay, but usually they are in a different name. They have different molecular structure. They have different physical properties, different kinetics in terms of reaction, different amino acid sequence, but they do the same role, the same reaction, but everything else is different about them. Name, um, properties, everything. As I said, they're different in their amino acid composition. So if you do the gel electrophoresis, we're gonna find, oh, this isoenzyme is heavier than this isoenzyme because it's composed of different amino acids. And of course, they're found in different tissues. This is the idea of isoenzyme. So let's take a quick examples from your older lectures: glucokinase and hexokinase. Each one is in a different tissue. One is working in the liver and one is working in another place. So, but it's the same reaction. Phosphorylating glucose, but different names, different tissue place. This is the idea of enzyme. Now, another example of isoenzyme, creatine kinase, CK. We have CK1, CK2, CK3. Each one is in a different organ, but all does the same function. Here, as I said, it's just because the gene makes these isoenzymes. Each one goes into a different organ, for example, but at the end, they do the same function. This is the example of isoenzyme I gave, creatine kinase. Creatine kinase, also called creatine phosphokinase. Okay, this is the reaction that it does. Takes phosphate group from the ATP and it adds it into the creatine to give us phosphocreatine. Phosphocreatine is just like, think of it as an energy reserve in the muscle. So you have like a good supply of energy, phosphocreatine, and it's quick supply of energy. This is the reaction. Now, creatine kinase enzyme is made up of two pieces, two monomers, M or B. So you can have either creatine kinase composed of MM, BB, or MB together. And this is what gives us the different isoenzymes. So the first one, CKMB, also called CK1, is found in the brain and lung. The second type, CKMB, first one CKBB, second one is CKMB. It's just found in the cardiac muscle. This is the most important thing. CKMM, found in the skeletal muscle. This is the idea. Now we're gonna, as we move into the slide, you're gonna be like, okay, there's a lot of enzymes. Each enzyme is in this tissue, or I have to memorize the specificity of each enzyme. So, like for example, here you have to memorize that TKBB is found in the brain and lung. TKMB is found in the cardiac muscle mostly. So, as we go through the slide, you're gonna see more examples of different isoenzymes, etc., and different organs. So, at the end, 1 second. At the end, I just collected all these different stuff and put them in one just big table for you. It's easier to memorize at the end. So yeah, the rest of the stuff throughout the lecture is just understanding. Okay. Bismillah. The second, we finished with creatine kinase, CK. We understood that it's found in these tissues. When there is damage of each tissues of these, we're gonna see increased level of this enzyme. So example, there's a cardiac muscle injury damage, you're gonna find in the blood high level of CKMB or CK2, and so on for the other organs. The other type of isoenzyme we're gonna talk about is LDH, also called lactate dehydrogenase. Of course, you took it in MOL1. Basically, this enzyme is needed for the anaerobic glycolysis. If you have anaerobic conditions, and then the end result is just lactate, this enzyme is used there. It's used in all tissues. Like the previous enzyme, it was like specific to the lung, cardiac. No, here lactate is just in all tissues because all tissue can do anaerobic glycolysis, right? That's why it's not very non-specific for the diseases in general. But it's specificity in terms of ischemia. So, if you see increased level of this enzyme, okay, this tissue has ischemia, was susceptible to decreased oxygen. Because decreased oxygen, this tissue went into anaerobic glycolysis. Now, these are the isoenzymes. LDH1 is found in the heart muscle, LDH2 is in the RBCs. So, in anemias, some kinds of anemias like hemolytic anemia, you're going to find increased level of LD2. LD5 is found in liver and skeletal muscle. So it's not specific. As I told you, we're gonna go through a lot of example. Oh, this is in heart muscle, this is in skeletal muscle. But at the end, that you have the table that I collected everything. You're just gonna have the big picture. You can memorize it from there. It's easier. So this is no need just to identify or memorize how the graph of this enzyme is shown, but just to explain the concept. This is the normal serum. We have normal levels of these enzymes because we have normal tissues turnover. If you have problem with the heart, myocardial infarction, you're gonna find that LDH1 spiked up, increased, while the others like proportionally decreased. If you have problem with the liver, we said LD5 is found in the liver. So if you have liver problem, hepatitis or whatever, you're gonna find that LD5 spiked up. This is the concept. There's no need to memorize any graph or anything. Okay. Now we will just keep on going with the enzymes and example and in which disease we see. So we'll go into the heart first. Myocardial infarction, lack of oxygen supply to the heart muscle, causes tissue ischemia and death of these cardiac cells, cardiac muscle cells. They're gonna rupture, they're gonna release their enzymes into the bloodstream. We can just know that this patient has myocardial infarction. Now, these are not all of them are enzymes. The only one is CKMB, is an enzyme. While troponin, myoglobin, they are proteins. We don't call them cardiac enzyme. We just call them cardiac markers. Okay, so these three are all collectively called cardiac markers. There is also a another you can have like as a cardiac marker. LD also is a cardiac marker. But because we discussed it earlier, we did not mention it here. But in the table, you're gonna find LD as one of the markers of cardiac problems. Okay. So these are the cardiac marker. What now? How do we know that okay, this cardiac marker is good, is not good? Each one has a pro and cons, and this will be like a key point in terms of exam question. Next slide. So the cardiac marker should be released if there is injury more than normal, because if it's normally released in a high level, then no need to use it as a cardiac marker. Should be cardiac specific. Some of these that I mentioned, they're found in skeletal muscle, etc. But to have an ideal cardiac marker, it should be cardiac specific, released by injury, and it should arise immediately after the problem, and it should stay long enough, so that you can detect it, because some patients, okay, might come after 3 days of the injury or problem. If the cardiac enzyme just rise and drop, then this is not very good for in terms of clinical diagnosis. We need it to rise quickly so that we can just detect it immediately, and we need to stay a good amount of time so that if the patient comes like a week later or so, we can still diagnose him based on the enzyme. It has to be easily measured. Some enzymes, some stuff, they take maybe days for labs to use to get the result out of them. So that's why we don't use them in medical practice, and we don't mention them even. So basically, in old days, they used only enzymes to diagnose MI, myocardial infarction, heart attack. But nowadays, we're using cardiac enzyme along with other cardiac markers, such as I said, myoglobin, troponin. These are cardiac marker, but they're not cardiac enzyme. Cardiac enzymes are CK, LDH, and AST. Okay. Okay, so for this, in old days, they only used the enzymes. They didn't know about the other myoglobin, troponin. They didn't use it. That's why they changed it. Whatever was here, the criteria of the committee, they changed it. Now the gold standard of diagnosis is the troponin, CKMB, the isoenzyme of the heart. We said CKMB, and they add into it ECG. This is how they diagnose heart attack. LDH that is not used. AST is not used because we're gonna see AST is found in liver problem. Okay, now how do we know it's cardiac or liver? LDH also is found, as I said, we had 5 isoforms of LDH. Okay. So as I said, question in the exam, what is the most specific, sensitive, whatever biomarker for heart? Immediately choose troponin. Okay. It's not an enzyme, it's a protein, but it's a cardiac marker. Now we'll talk about the troponin. I'm not sure if you took MSK or not yet, because they changed the blocks arrangement. But this is not the idea here, just to understand, how muscle contraction, no. We have 3 types of subunits, okay, of troponin. Troponin I, troponin C, troponin T. Troponin C, where calcium binds. Troponin T is attached to tropomyosin, that's why it's called troponin T. And we have troponin I. There's a different way of how do they like unwind in terms of muscle contraction. This is not the focus of this lecture. Troponin C is calcium binding per area. I is inhibitory, where ATP has activity blocks. And troponin T is where tropomyosin just attached to it. Now, out of these 3, I and T are skeletal cardiac isoform that are different from skeletal. The C is just found in muscle and skeletal muscle and cardiac, so it's very unspecific. But for in terms of I and T, these are more specific to cardiac tissue. Of course, this is very advanced. There's difference between I and T. Some is used. One is used in renal problem. One is used, but for your level, just I and T are the same. They're cardiac markers, more specific, most sensitive for cardiac injury. They rise in terms of cardiac problem or acute myocardial infarction, but they don't rise in skeletal muscle problem. So if we see them high in the blood, this is most likely like 90% plus. This is a heart problem, just unlikely to be a muscle problem. I and T. That's what you said, most specific and sensitive. They stay for like 10 days or 2 weeks. Features of ideal cardiac marker. Now, it says here limited re-infarctional diagnosis. I'm going to explain why that. Myoglobin, another cardiac marker, another protein, early marker, first to rise. This one immediately rises within 1 to 2 hours, immediately rises. But myoglobin, from its name, myoglobin is found in muscle, whether cardiac, skeletal, so it's less specific. But the key feature here, it's first to rise. Also, an exam question, what's the fastest enzyme to rise in terms of heart attack? It's myoglobin. It rises within 1 to 2 hours. The third cardiac biomarker is CKMB. It's less specific, of course, than troponin. Myoglobin also less specific because they might rise in skeletal muscle. But CKMB has special features. So, as I said, myoglobin has special feature. It rises immediately. CKMB has another special feature, which is it stays elevated 1 to 2 days only, and then after that it drops. Patient has heart attack. This CKMB rises, stays up for 2 days, and drops back. Okay, so on the third day, if you want to check if the patient has another heart attack, you're gonna check the levels of CKMB. If you find it high, then you think, oh, patient had the one attack, and then the rise rose and fell down. On the third day, I find it also elevated. That means the patient had another heart attack after the first one. But if you did the troponin test stay high for 10 days. So when you measure the troponin on the third day, okay, this patient might still have the troponin of the first heart attack. He might not have a second heart attack. How would I know? I just go into CKMB, and this will exclude whether the patient had a repeat heart attack or not. As I said, troponin plus ECG are the gold standard diagnostic measures used in clinical practice for a heart attack. This is what I was saying. Myoglobin immediately starts. CKMB starts and falls quickly within 2 days. Troponin stays high for 10 days to 2 weeks sometimes. Just memorize the feature of each one of these. There might be in terms of the exam. So see here, as I said, patient comes on day 3. I measure cardiac enzyme. Their troponin might be high from the first infarction, but how would I know the patient had another infarction or not? I measure CKMB. If I find it low, then that means the patient did not have any other heart attack. But if I find it high, that means the patient had another heart attack here. After the second day, another peak. So this is the idea. Now we finish the heart, we go into the liver. We have 4 enzymes to check in the liver: ALT, AST, ALP, and gamma GT. Now these are enzymes, but if you say liver biomarkers, liver profile, it includes these enzymes plus other stuff like albumin, like bilirubin. When you're doing actually GI now, so you know these stuff. So albumin, bilirubin plus these enzymes are all called liver profile or liver biomarkers. Now let's start with ALT and AST. Just no need to memorize this: glutamate, oxaloacetate, pyruvate. This is not the scope of this lecture. Just know that their name, first one is called alanine aminotransferase, ALT. The second one is aspartate aminotransferase. From their name, aminotransferase. So they transfer amino group from one thing to another, and they give us different end products. This is the idea. Now, what you need to know is the feature of each one of them. Both of them are elevated in liver damage or liver disease or whatever problem in the liver. Both of them will rise, okay, because they are there in liver cells. When liver cell get damaged, the enzymes will leak. As we said, the concept is just the same as any other organ. Of course, viral hepatitis or any other hepatitis, not necessarily viral hepatitis, but viral hepatitis is very special. It just drastically increased the level of these enzyme, ALT and AST, both of them, 20 to 50 times the normal range. Normal range is there, multiply 20 to 50 times. This is when you see this is like high likelihood of like viral hepatitis. Now, you have elevation of ALT is more specific. Now, both of them are increased in liver damage. ALT, AST, both of them. Now, what's if they ask you most specific or most liver specific enzyme used, or which is better if you want to just use one. Okay, for usually both of them are ordered. Okay, in terms of cardiac, you can choose not all to here. Usually they're both ordered, but if you chose one, you choose ALT. Memorize it. L, liver. This is the most specific for liver, but both of them are used for liver testing. Why? Because AST is found in liver and muscle. See, muscle just shares with everything, with every organ, but ALT is more specific to the liver. Now you have to memorize, like this red is just like important thing you have to memorize. Now sometimes the proportion or the way is different between ALT and AST. So if you have ALT is increased like 30 times, AST is increased like 10 times than normal. There is difference between the increased ratio, right? So if ALT is more, this suggests whether it was fatty liver disease, viral hepatitis, mild liver damage, you know. So this is like also might be an exam question. You're gonna find ALT increased 30 times normal, AST increased but 10 times normal, for example. So it's the differentials is one of the following. Now, what if AST is increased 50 times, ALT is just increased 20 times than normal? This is just specific for alcohol disease, just one disease. AST more than ALT, both of them are increased. Both of them are increased because it's liver damage. But when one is increased more than the increase of the other, then you have like just to see which differential is the likely cause. And it's alcohol disease in terms of AST. We finished AST, ALT. Let's look at another liver enzyme, which is alkaline phosphatase. Some of them say alkphos, ALP, all the same. So just to understand here, it just liver cholestasis. What's cholestasis? You're doing GI. If there is a blockage in the bile duct and there's accumulation of bile, backflow of bile, you know, this is called cholestasis, whether the bile duct was blocked, whatever level sphincter of OD, common bile duct, whatever. It's like we're not focusing on that. Just there is a bile duct problem, you see increased level of alkphos. Also, this enzyme has a role in bone buildup and degradation. You know, any bone problem, you can see this level of this enzyme increase. Here's the second enzyme. Let's see the third enzyme called gamma glutamyl transferase, gamma GT. You know, it's enzyme in the glutathione metabolism. No need to check which step or whatever. Here also it is an indicator of a bile duct blockage or bile duct damage. Okay, same as alkphos, but what's the difference here? It is specific. What does that mean? We don't see it if there's a bone problem. We don't see increased level of GGT. No, just in bile obstruction we see increased level of GGT. So usually, if you want a patient has jaundice, whatever signs of cholestasis, you want to know the cause. You can't just order one. Maybe there might be a different problem, because if you ordered, usually no, you can order GGT. If it's positive, then that means there is cholestasis. But you can't order alkaline phosphatase alone. You can't. Why? Because if it's positive, okay, this alkphos might be positive because of bone problem or cholestasis. But if you get GGT and a GGT is positive, then you're confident that this is a bile duct blockage or cholestasis problem. Now we finished the liver, we finished the heart. Let's go into the bone. Bone, only one enzyme we have to know is the one that we mentioned a bit ago, alkaline phosphatase. No need to know which step it has a role in. It just increase in the bone diseases, whether it was rickets, osteomalacia, Paget's. So here they're just mentioning the definition of Paget. What happens in Paget disease? Paget disease, there is increased bone, but this increased bone size is just weak bones. So they have weak bones and risk of fracture or whatever. This is not the scope, but just any bone disease, any of these, which enzyme would be elevated, it's gonna be alk-phos. Finished bone disease. Let's go into salivary gland disease. Any salivary gland disease, whether it was stones in the salivary gland, ducts, whether it was mumps, it's a viral infection to the parotid gland, you're gonna see increased level of amylase. Okay, this enzyme is found in the salivary gland. Increased level, there's a problem in the salivary gland. What's the problem? We're not sure. Other diagnostic measures, you check viral levels, you can just imaging for the gland to see if there is a stone, but increased level of this enzyme, there is a problem in this organ. Whatever was the problem, it's just it really can't tell you exact the problem, but it just tells you there's a problem in this tissue. This is the idea of enzymes. Let's go into another organ, pancreatic diseases. Also, you're doing GI, you know these. Amylase, lipase, both of them are found in pancreas. They just, in the pancreatic juice, they have role in digestion, etc. Now, both of them are increased in acute pancreatitis, okay? But one is better than the other, as always. Lipase is better than amylase. Why? Amylase, we saw it in salivary gland, so it's not specific for pancreas, right? Lipase is specific for pancreas. That's why it's better and more specific in terms of diagnosis for pancreatic problem. Now, all of these, what we have mentioned was diagnostic use of enzymes in clinical settings. Now, can we use enzymes in terms of therapy? Yes, we can. And we can use it in terms of lab. We're going to see later on. Let's see what therapeutic options we can with the help of enzymes. So they mentioned 3 examples, although this list just goes endlessly, but just here they just gave you a sample of enzyme use as a therapeutic. So for example, if you have pancreatic problem, pancreatic insufficiency, pancreas is releasing enzymes, but there's a problem in the pancreas, you need an enzyme of pancreas for digestion, you just give pancreatic enzyme replacement. Trypsin and lipase, you give it as a replacement. This is one use. Other use, asparaginase, leukemia. Asparaginase can be used in terms of treating leukemia. Leukemic cells can be, killed with asparaginase enzyme. The third therapeutic option is if you have a clot in the blood, this clot, whether it's in blood or in the heart or in the brain, usually either you just go with the catheter just to remove the clot, or you administer enzyme. You administer enzyme in the blood. This enzyme would go and degrade the clot and dissolve the clot. So you have a couple of examples here: tissue plasminogen activator (TPA), urokinase, streptokinase. All of these are enzymes given just to dissolve clot in terms of any clots, whether it was in the leg or in the heart. So these are examples of therapeutic enzymes. Let's go into the third application of enzyme, which is in terms of laboratory use. I'm not sure if you took this in MOL 1, how you do ELISA, how you do DNA extraction, how you do Western blot, these stuff. But basically, these are 2 uses for enzymes in lab. Whether you just analyze the DNA with different technique, whatever was there, or ELISA for, I'm going to show you ELISA in a bit. These are the DNA analysis technique. You use enzymes, use restriction endonucleases, DNA polymerases, DNA ligases. It's like lab stuff. ELISA, you use an enzyme in ELISA when you want to just check if you have a protein in the blood. Okay, you want to diagnose it using ELISA. So this is how ELISA works. This is the target protein. You, in the sample, you put antibody, and with this antibody there is a enzyme attached to it. When this antibody binds to the target protein in the patient sample, this enzyme that's there in the antibody would like give a different color, different shape, and you know that, oh, this is the patient has a positive result of this protein, for example. This is another use of enzymes. Now, this is the table I was telling you about. This is basically whatever we have mentioned throughout the slides. If you like, just memorize this, you know, each enzyme, which disease, which organ, you know. Also, this one, the same, but just here it's from a book. Memorize it, also know which disease and which level. It's just easy. This one, last one, and nucleotide we did not mention, but just like for the sake of completion, they put it here. Now we have just quick 3 questions. They're easy, you know. The lecture is easy. Does anyone wants to read or answer? Or should I do it? Okay. So first, which of the following enzymes is not used in the diagnosis of an MI? We mentioned LD, LDH can be used. Creatine kinase, CKMB isoenzyme is used in diagnosis. Aspartate transaminase also increased in liver and can be seen in cardiac and skeletal muscle. But alanine transaminase, the ALT, it's only in the liver. The AST, which is this one, can be seen in liver, can be seen in muscle, can be seen in heart. What about aldolase? Aldolase, we did not mention it. So it just, it's not in the cardiac markers. So the answer is A. Next one, which of the following is not a plasma non-specific enzyme? Okay, so it's confusing. Not and non-specific. So just remove not with non, like negative, negative, remove each other. So which of the following is a plasma-specific enzyme? This is how you solve the question. So which of the following is the enzyme that is usually found in the plasma and has a role in the plasma or in the blood vessel? This is what they're asking for. So alanine aminotransferase, ALT, this is in the liver. Aspartate also is in the liver. Aldolase, I'm not going to confuse you with aldolase, just is not in the, does not work in the blood. Enzymes involved in blood coagulation. This is the correct answer. Enzymes that has a role in plasma coagulation and clot formation or clot removal. There's enzymes for clot formation and there's enzymes for clot removal, but these are plasma specific enzymes. This is the answer. Third last question, what cardiac marker can be detected for the longest period of time post NMI? Myoglobin rises quickly and falls quickly. CKMB rise a bit later than myoglobin and falls after 2 days. Troponin rise after CKMB by a bit and stays for, we said, 10 days to 2 weeks. Troponin can stay. So the correct answer is troponin. Now with that, I have reached the end of my lecture. Hope you understood the concepts and just one slide to memorize the enzymes, and then you're good. If you understood the concepts, this table, you memorized it, you're good to go. If you have any feedback, please feel free to just submit it through this form. Other than that, if you have any question, I'll be more than happy to answer you.